Hello, and thank you for joining our program, Expert Insights on COVID-19 Vaccinations and High-Efficacy Therapies for Multiple Sclerosis, an MS Teamworks Forum. This program is jointly provided by the Consortium of Multiple Sclerosis Centers and Catamount Medical Education, and is supported by Novartis Pharmaceuticals Corporation. Today's panel includes our program chair, Dr. Scott Newsom. Dr. Newsom is an associate professor of neurology and the director of the Neuroscience Consultation and Infusion Center. He is the director of the Stiff Person Syndrome Center and co-director of the Multiple Sclerosis Experimental Therapeutics Program. Dr. Newsom is also co-director of the Johns Hopkins Neuroimmunology Clinical Fellowship Program and a member of the Milson-Colson Academy of Clinical Excellence at Johns Hopkins Hospital, Division of Neuroimmunology and Neuroinfectious Diseases. Dr. Ann Cross. Dr. Cross is professor of neurology and the chair of neuroimmunology at Manny and Rosalind Rosenthal and Dr. John L. Trotter MS Center. She is also the section head of the Neuroimmunology MS section at Washington University School of Medicine. We hope that you find this program informative and useful in the care of your MS patients. At this time, let's welcome our program chair, Dr. Scott Newsom.
Welcome to Experts Insights on COVID-19 Vaccinations and High-Efficacy Therapies for Multiple Sclerosis, an MS Teamworks Forum. We are really excited for tonight's program. I'm working with my partner in crime, Dr. Ann Cross, who I've had the fortunate pleasure of working together on many different steering committees, including the National MS Society COVID Vaccine for Patients, COVID-MS Registry, and other initiatives. So we hope that this program is informative, and we want to get through the didactic portion of this in a quick way so we can get to the question and answers section. Without further ado, I think most of us on the line here realize that there have been a number of groups who have come together during this COVID-19 pandemic, putting their heads together to try to figure out what are best guidances for people living with MS as it relates to COVID-19 vaccines. Now, some of the data that is out there that are being leveraged is from older pre-pandemic vaccine studies in our patients. Some are ongoing studies that are being monitored very closely, and others happen to be expert opinion from researchers and medical professionals. And so, the 50,000-foot view high points are that groups around the world are, recommending our patients with both relapsing and progressive forms of MS to get vaccinated. And especially those individuals who are deemed as high risk. And you can see here in the little, middle of the slide here, those that we are deeming high risk. And some of this is not just exclusive to people with MS, right? We know from the general population that those who are older, who have more comorbidities, African-American, Hispanic descent are at greatest risk to have severe outcomes as it relates to COVID-19. And, so the guidance here is really a combination of opinions and data-driven. But we do know that the guidances are evolving, just like what we're learning with relationship to COVID-19 and the vaccines. So very high level, I'm just going to spend a minute or so on this slide. It's a sort of heavy slide. I think most of you, if you're watching TV or on social media, you've probably seen the data that's in this table here. These are the three current approved vaccines that we have here in the United States. The first row there, the Moderna, second row, Pfizer, third, the J&J. And as I think all of you are aware, the Moderna and Pfizer are mRNA vaccines, so they work on a different vaccine platform than the traditional vaccines that all of us are familiar with, like the flu vaccine, for example. The J&J happens to be an adenovirus vector. This is not a live vaccine. It's a non-replicating vaccine, and Anne is going to go through sort of the mechanism of action of these two platforms to give you a better idea of what's happening in each of our bodies when we get these vaccines and the immune response associated with it. Now, what was really impressive to me when we look at the phase 3 clinical trial program for these vaccines is how effective they were in preventing contracting COVID-19 and also further in preventing severe disease. And the severe disease meaning hospitalizations, ICU admission, and death. And so you can see maybe there are some nuances in terms of the percentile decrease in preventing COVID-19 amongst the different vaccine platforms here, but all in all, very effective, and especially if you compare the numbers here to prior vaccine studies, and I would argue that these are some of the most robust numbers that you'll see in preventing, of viral infection. Now, you may look at the number and say, well, I prefer this vaccine over another, or you're telling your patients there's a preference here. But I can tell you that we're, as a group, saying there's no preference. And really the message is get vaccinated whichever vaccine is available to you. And the other thing, and you've probably heard Dr. Fauci say a number of times, a person is not fully protected until 2 weeks after their last vaccination shot. So 2 doses, of course, with the mRNA vaccines, 1 dose for the vector vaccine. So, Anne, why don't you take us through the mechanism of action of the 2 vaccine platforms to give our audience an idea of how these work, and then give us a little more information about what we're seeing as a group in terms of the COVID vaccine for our patients and what other, deeper dive recommendations.
Great, thank you, Scott. Yes, I think I totally agree with you that these are extremely effective vaccines. So as most of you know, the SARS-CoV-2, which is the virus that causes COVID-19, has on its surface a spike protein that you can see here in green. And those are proteins that stick out and kind of look like a crown, and that's how they got the name coronavirus. And they bind to the ACE2 receptors, which are on many different cells in the body. And the part that's closest to the red receptor there, the ACE2 receptor, is called the receptor binding domain. And all of our vaccines are going against the spike, are targeting the spike protein. So this is the slide on the mechanism of action of the messenger RNA vaccines, and it's a little bit busy, but I'll sort of walk you through what I know about it, which is that, so messenger RNAs, if you ever work with them in the lab, you know they are extremely unstable. And so what people had to do, and this was done many years ago, is figure out that what you could do to alter mRNA. And one thing is to change uridine in the RNA to a N1-methyl pseudouridine, which can take its place, and that stabilizes it. And then what they did, so they took the mRNA for spike protein, and they encapsulated or put it into nanoparticles of lipids, so lipid nanoparticles. And those particles protect the mRNA as well. And they also facilitate it crossing membranes, cell membranes, to get into the cytoplasm of cells where it can be translated into the spike protein. So, so what happens, we think, is when you get the injection in your muscle, antigen presenting cells called dendritic cells, which are in the tissues, see this, or these nanoparticles are taken up or go through their cell membrane and release their mRNA in the dendritic cell, where it is translated into protein, and that protein then is taken with the dendritic cell into the draining lymph node nearby. And probably some of these lipid nanoparticles containing the spike mRNA that has been stabilized and it's in the pre-fusion state also get into muscle cells and other cells where it may be expressed as well, and dendritic cells may take it up from there. But in any event, the dendritic cells do what they always do, which is travel to the lymph nodes where they can encounter T cells and B cells and activate them. And this antigen that they have produced themselves, the spike protein, is taken up by follicular dendritic cells, which are in the germinal centers, and germinal centers are created where the B cells are then B cells that have a B cell receptor on their surface that will recognize the spike protein, will see it, and then undergo somatic hypermutation to very avidly detecting antibodies or B cells that have a cell receptor that will very avidly detect the spike protein. And then in addition, these dendritic cells can activate the CD4 and CD8 T cells, and CD8 T cells are very important in viruses because they are cytotoxic to virally infected cells. So it's a very detailed process that I'm not even certain is fully understood, but people have been working on this for years. And there's a reference here to a paper by Bettini, which I read, and I really recommend it to you if you're interested in learning a little bit more about this process. So that is the mRNA vaccines. And then there are the vectored vaccines, and the J&J vaccine, as well as the AstraZeneca, which we don't have here, are vectored vaccines. And so it's an adenovirus that, as Scott mentioned, is not replicating, so it doesn't proliferate, but it's been made to be somewhat of a Trojan horse where you can put in the messenger RNA of the spike protein and it will express it. And so these adenoviral particles that cannot replicate but contain the spike protein messenger RNA get put into the muscle with an IM injection, and then they are taken up by dendritic cells as well through endocytosis mainly, and they get in and they can either release the mRNA in the adenovirus into the cytoplasm where it is translated into protein that can then go to the surface and activate CD8 T cells, as well as the dendritic cell, again, trafficking to the draining lymph node, and the spike protein is there. I think one of the important things to know here is that the full SARS-CoV-2 virus is not encoded in any of these vaccines. It's only this one protein. There is no way that this can infect you. It's not a full virion. So, so that makes it, I think, particularly safe. I will just mention that the J&J vaccine, as probably you've heard, was temporarily paused when there were a few rare venous thrombotic events that occurred in young women under 49 years of age. So I think right now they are not recommending that this particular vaccine be given to women under 48. So, so what about the safety of these vaccines, particularly in in people with MS? I mean, we know that in general that in the late phase 2 and phase 3 trials of these vaccines, we don't know how many MS patients were in those. And in some of the early phase trials, people with MS were left out of it, were not enrolled. But I'm going to, in a moment, discuss a large Israeli study that did look at safety in MS patients in particular. But what I'd like to say here is that in general, vaccines have been found to be safe and effective for people with MS. And by in general, I mean other vaccines, such as, these are ones that have been studied in MS, hepatitis B, human papillomavirus, seasonal influenza viruses, MMR, tetanus, BCG, which is used in some other places in the world against TB, polio, typhoid fever, and diphtheria. And some studies are still ongoing with yellow fever. But basically, all of those vaccines have been shown to be safe and not to cause relapses or MS itself. So because these vaccines have been considered safe and effective based on these prior studies, the general guidance for people with MS has been to be vaccinated when appropriate for you. And if you are about to begin a treatment, the guidance has been to try to vaccinate prior to the initiation of any immunosuppressive medications in particular. And if you happen to be having an MS relapse at the time, it has been recommended not to wait until the relapse has resolved. So in terms of live attenuated viruses, the general guidance has been to avoid live attenuated viruses in people with MS, mainly people who are on immunosuppressive agents, just in case. So what about the safety of COVID-19 vaccines in people with MS? As I mentioned, we don't really know how many people were in the original studies, but there was this study from Israel. So in Israel, they got a huge amount of Pfizer vaccine as somewhat part of a study, and their whole population was offered the Pfizer vaccine, and pretty early. And so that's a 2-shot mRNA vaccine. And they found that, for example, the rate of acute relapses in the 20 days after the first shot, and this was in over 500 people, by the way, that had MS, that the rate of relapses after that first shot, 20 days after that, and after the second shot, slightly lower numbers of people in that, 435, up to 38 days after that second shot, that the risk of relapse was 2.1% in that 20 days after the first and 1.6 after the second. And so this particular center, which has a huge number of MS patients, it's in Tel Aviv, it looked back at the years 2017, 2018, 2019, and 2020 to see what the rate of acute relapses were in similar populations for similar periods of time. And it was hovering between 2.3 and 2.9%. So you can see that it does not look like there was any increase in relapse rate after the vaccine in these patients. So it should be noted that in some people, and we've seen this as well, that you can have symptoms after the vaccine, and they're just pretty much the same symptoms that everyone else has, of sore muscles, sometimes fever, sometimes nausea, a lot of fatigue, headaches, and occasionally this can worsen symptoms of MS, as we know, the sort of what we call pseudo relapses, and that can occur temporarily. This is from that same study that I was just mentioning with all the over 500 people in the Israeli study. And these patients got the vaccine between December 20th and January 21st. So these 555 patients are all from that period of time. And they found that there were no episodes of anaphylaxis or life-threatening responses immediately after these vaccinations, and that the adverse event effect rate was about 30% after the first one and 40% after the second. And this particular slide is broken down to look at people by age, breaking at 55 years, and by disability, and by whether they are on a disease-modifying therapy or not. And as you can see, there are a little bit more vaccine side effects, pretty much the same one everybody else sees in the younger people, in those people who are less disabled, and in those on immunomodulatory drugs, and a little bit more after the second dose than the first. And that's pretty much what people have been noting in general. So now I'd like to ask Scott what we know about the effects of disease-modifying therapies on vaccine responses, and how can we relate that to the COVID-19 vaccines?
Yeah, thank you, Anne. And so for the audience, there was a last quick change. So Anne felt like she wanted to give me the harder part of this webinar and to put me sort of in the fire with discussing this, because obviously this is probably one of the more important topics for our patients. I think Anne did a beautiful job going through what we know about the vaccine, how it activates the immune system, showing the data that she just showed in patients with MS. So this is, again, not general population, but patients with MS and the safety around it as it relates to relapses or lack thereof, I should say. So why do we care? Because when Anne showed you the vaccine response from the mRNA and also the viral vector J&J, it's all about the B and T cells, right? So the B and T cells, the adaptive immune system, is what gets activated. And we know that all the therapies we have available today that are FDA approved for treating MS target the adaptive immune system, right? And so this is why we care. And there are a number of factors that can really impact the vaccine response. And some of this happens to be the vaccine type, including the number of doses, the type of response, meaning, if someone has had a vaccine for a number of years over and over yearly, like the flu vaccine, versus what they call a novel antigen, like the COVID-19 vaccine. This would be considered sort of in that bucket of novel antigen. And then also, what is the robust impact on the adaptive immune system as it relates to the disease-modifying therapy? And you heard Anne mention about immunosuppressant therapies. And as we know, and why we're doing this webinar, the therapies that are deemed higher efficacy have a more robust impact on the immune system, which can translate into an attenuated vaccine response. And we need to know how this plays out in our patients, especially during a pandemic and beyond. What I would say, and we're really at the tip of the iceberg with this, is that all the data we have right now relates to the humoral vaccine response, the B cells, the antibodies. What we don't know, and hopefully here in the coming months, is what's happening with the T cell response, the cell-mediated immunity after someone gets a vaccine. And why this could be important is if you're measuring an antibody in the blood and say it's low or not present for that spike protein as it relates to COVID-19, that does not mean that they have zero protection. They actually may be protected. We just don't know how much protection they have and whether there's enough protection to prevent infection, de novo infection, or if they get infected, more severe disease. So Anne had gone through a very nice study showing, again, the safety of the vaccine in our patients as it relates to relapses. This same group, because they were offered a lot of Pfizer vaccines, as Anna mentioned, wanted to look at, well, does it make a difference with the vaccine response based on the medication that someone is on versus not being on a medication versus healthy controls? And this is sort of a busy slide, but I'll try to walk you through it. So over 100 patients were in this study. They received the Pfizer vaccine, and then they were, their blood was measured to look at the spike protein for SARS-CoV-2 a month after their second dose. And you can see here in this table, the treatment group is split up with MS patients, those that were untreated, so currently on no DMT, those that were on cladribine, those on fingolimod, those on ocrelizumab, and then a sampling of healthy controls. And what you can see, I think, nicely illustrated here is that patients who are untreated, so i.e. not on any disease-modifying therapy, and those that were taking cladribine had actually a good humoral response after getting vaccinated, very similar to what we see with healthy controls. Now, what you can clearly see here, and this is percentage of patients having a response, in those that were on fingolimod and ocrelizumab, there was an attenuation of that vaccine response. So not as high titer antibodies in the blood when it was measured. And interestingly, more so with fingolimod, so much greater attenuation even compared to ocrelizumab. Now, if you look at sort of this middle little graph here, which is very tiny, and I don't expect anyone to be able to see it, but what this is basically saying is when they looked at the vaccine response as it relates to the lymphocyte count, the peripheral lymphocyte count, was there a difference in that vaccine response, a humoral response? And what was seen, interestingly, is there really did not seem to be a correlation with the lymphocyte count. So, for example, patients on cladribine, no matter how high, how low the lymphocyte count was, they still mounted a good humoral response. Similarly, you can see with the healthy control population, there was a sort of wide variation of lymphocyte count, and there, same deal. And with ocrelizumab, which again is kind of tiny to see, but there was no real major difference in terms of vaccine response based on how low the lymphocyte count was. But nonetheless, again, the same message is that fingolimod, ocrelizumab, there seemed to be an attenuated vaccine response that was independent of the lymphocyte count. And then the little graph to the right of this slide, this was looking at, from time of last medication administration. So why they were interested in looking at cladribine and ocrelizumab, as you guys know on the line, is that these are infrequently administered medications, right? And so is there a difference with the vaccine response on day 2 versus 4 weeks or 2 months out from the last medication dose? And what you see here, similarly to what I mentioned with ocrelizumab, there seemed to be a blunting effect of the vaccine response. And in fact, a lot of patients actually had no measurable antibody within the blood. And then with the cladribine treated individuals, you can see across the board that there was a humoral response. And that was not dependent, actually, if you look at from time of last dose. But again, I'm going to echo this again and again, and I think when Ann and I go through the Q&A session, this does not mean that if the antibody level in the blood is not present or it's low, that there's absolutely zero protection from COVID-19. We need more data to really help sort that out. So many of you on the line are probably aware of this Veloce study. Now, this was a pre-pandemic study that was done looking at what is the impact of some of the common vaccines when people start ocrelizumab versus interferon beta or no therapy. And this was a phase 3B randomized trial, 2-to-1, so 2 in favor of ocrelizumab. And that's why you can see the numbers are a little bit different, 68 people on ocrelizumab, 34 in the control group. And so the high points here, in interest of time, was sort of a common theme. So individuals that were randomized to ocrelizumab, who then got vaccinated with these various common vaccines, the tetanus, pneumococcal influenza, and then a newer vaccine, KLH neoantigen, had a less robust vaccine response than the individuals in the control group. And you can see the percentages here. That's broken down by the rows for the individual vaccines, and then the on the columns here, ocrelizumab versus control. But again, what does this mean for our patients who may be on B-cell depleting therapies? It doesn't mean that they're not protected at some level. It just means that there is an attenuated response to vaccines in general. And so, why is this important? I mean, I think for all of us that see patients in clinic and face this challenge, especially during a pandemic, when do we recommend getting the COVID-19 vaccine? Especially now that we're seeing many states have more availability to it. Is there a timing, an optimal timing that we want to put in place for our patients in holding dosages of medication or waiting for the right time to get vaccinated. Now, when there was less availability for vaccines, I think all of us were just saying, whenever you have the opportunity to get vaccinated, stick out your arm and get the shot. Now it may be a little bit different, but still, I think this is a shared decision making, and you have to look at the worsening of MS in terms of, do we hold back, let's say, B-cell depleting therapy for a period of time in order to get that optimal timing and risk someone's MS activity, rearing its ugly head, versus the risk of COVID-19 and getting that. So what are some of the guidance recommendations out there? So not guidelines, I just want to be clear on that. These are not guidelines. This is guidance from the National MS Society, and also in parallel and mirroring this is the MSIF, is that if someone has stable MS and they're going to start a medication or continue on a specific medicine, you can see in the top here, those that are on beta interferons, fumarate, sclerotimer, natalizumab, teriflunomide, it's felt that there shouldn't be any sort of disruption or any issues with starting or waiting to start a medication as it relates to COVID-19. And in part, prior studies with vaccines, these medication classes don't seem to really impact the vaccine response in a negative way. Maybe there's little nuances here, but not enough to make the person less protected after getting a vaccine. Now, that's not the case with immunosuppressant therapies, and some of which I already went through with the data from the recent studies. And so again, you have to look at it, at least my view is a case-by-case situation if someone's on a specific immunosuppressant drug. Very busy table, just the high points here. For the medications that we deem as higher efficacy, and there could be some differences of opinion with some of these therapies. But if someone is going to start one of these therapies, S1P receptor modulators, alemtuzumab, cladribine, any of the anti-CD20 monoclonal antibodies that are infusibles, and then ofatumumab, this is some of the data here, or the information here is based on prescribing information, expert opinion, vaccinologist in terms of when you get vaccinated, how long do you have to wait for the vaccine to be most effective, as we mentioned, the 2 weeks. So here you can see 2 to 4 weeks prior to starting a therapy, we recommend getting vaccinated, having that second shot if it's the mRNA, or the one shot within this time frame or before the time frame starting. And then if someone's already on therapy, this is where it's a little bit dicier, honestly. And I think we could spend a whole weekend going through this, even with one medication and going back and forth. But in the interest of time, I'm not going to go through this in detail. The guidances are on the National MS Society website. And I think you just have to realize that some of these guidances are in evolution as we learn more about the impact of these drugs on the vaccine response. These guidances will be updated. And I think in the Q&A, we'll get a little more granular on some of these guidances. So corticosteroids, some of our patients will have relapses, right? And some patients will either be on therapies currently and have a relapse and have breakthrough disease activity. Other people are going to be newly diagnosed, treatment naive, having relapses and coming off of corticosteroids. So when should we recommend our patients to get the COVID-19 vaccine as it relates to corticosteroid administration? So in speaking with vaccine experts, this is the recommendation, and it comes from knowledge around vaccines and how long is the immune effect after getting corticosteroids. Now, it differs depending on whether it's oral or IV, but this is sort of the take-home message, at least waiting 3 to 5 days after the last dose of corticosteroid, whether it's IV or oral. Okay, so I think we can get into hopefully a nice robust discussion. Now, I told Ann and others before we started that I'm going to punt all the hard questions to Ann, because she's much smarter than I, and she has been in the humoral world of things. And if you've read Ann's work, it's incredible as it relates to B-cell therapies and others. So it should be fun. So I'll propose this first question, and these are, we asked some of you, I guess, in the audience submitted some questions beforehand. So we're going to go through some of these now, and then there are going to be some live questions as we're talking that you guys are entering in, and we'll try to do our best and answer as many as we can. So Ann, you and your colleagues, what has your experience been in practice as it relates to COVID-19 vaccination with people receiving the vaccine and on these specific therapies? It's sort of an open-ended question.
So I'm hesitant to give my own personal experience because it may be skewed in one way or another. And thank you, Scott, for giving all that information on responses to vaccinations with different MS therapies, because I would, guess that I would want to point to those studies as being perhaps able to be extrapolated toward the COVID-19 vaccination. And then the reverse question, since I'm not 100% sure what the question exactly is here, might be what happens to people when they get COVID vaccination and on different therapies, like in terms of side effects or risks to them of relapse. And the Israeli study from Tel Aviv University was really helpful in that regard, but they only used the Pfizer mRNA vaccine, but they did not see an increase in relapses and very little in the way of pseudo relapses. And I would say that I have been very pleasantly surprised that I haven't been hearing, most of my patients, or probably at least half, are vaccinated now, and I'm not hearing a lot about pseudo exacerbations from the side effects of the vaccine.
So it must be different in the mid-Atlantic, because I can say that quite a few of my patients after getting vaccinated have reached out with amplified baseline symptoms, or even interestingly, which I still am trying to wrap my head around this, is their initial presenting symptom of their MS, which they haven't had for years, is now resurrected, so to speak, after getting vaccinated. But then, goes away, and we wouldn't consider it a relapse. But that is really of interest, and I agree. I think we have to be cautious saying too much, because I think we're still learning as a community. But I am reassured, at least in think that we haven't seen relapses. In terms of the blunting effect for the higher efficacy therapies, I guess right now it's too early to tell whether some of our patients on, let's say, B-cell depleting therapy or S1P modulators, are they going to get infected even though they got vaccinated? I think that is critical, and we don't have that information yet. Hopefully we do soon. Next question. Should lymphocyte counts be assessed prior to vaccination in patients receiving certain higher efficacy DMTs? So I'll just point people to that publication that I briefly went over with the humoral response. And again, only a few different medications were looked at in that trial, but showing that the lymphocyte counts did not seem to, at some level, be associated with an impaired vaccine response when you look at sort of the tertile of lymphocyte counts. However, with that being said, I usually check lymphocyte counts on all my patients pretty frequently, so I would do it in general. But what are you doing, Ann, with this?
I think we're doing about the same thing. I was reassured by that paper that you just presented, that probably the lymphocyte counts are not what we need to be paying attention to so much, but of course we want to look at it in terms of just the safety of the patients on the different disease-modifying therapies. So I have not seen too much that seems to point toward this being a really critical factor, lymphocyte counts.
Yeah, and I think I think of a scenario like, let's say you have a patient, you check their lymphocyte count, just their normal sort of surveillance labs, and their absolute lymphocyte count is 500 versus, someone else who's 1,000. Based on that study, and again, it's one study, but I think it's reassuring to say, for me, I would go ahead and recommend pushing forward to get the COVID vaccine. So I wouldn't have any reservations to say, okay, they're going to be unsafe to get the vaccine because their absolute lymphocyte count is 500 or 400. So I think that maybe that's what whoever asked this question, which I think is a great question, is getting at. Is it safe? And I would say yes. Okay, so this is one of the big questions that's out there, and I'm gonna, again, hard questions I'm turfing to Anne. So is it necessary or helpful to obtain serological confirmation of a response after vaccination in some patients? So what are your thoughts there?
So thanks, Scott, for giving me this question. I do not know the answer to this. I can tell you that I get this question on a daily basis from people that I care for, and I have indeed checked it in a few people, and I would say that in the handful, I mean less than 5 that I have checked it, who are on a B-cell depleting therapy, we haven't seen a humoral response to the spike protein. So it has been very disappointing to them, but on the other hand, we don't know what their T-cell response is because that's the harder thing to check, and we don't have a commercial way to check it. But I think it does behoove us to tell people who are on these immunosuppressive agents in general, particularly the B-cell depleters, to get vaccinated, but to still wear a mask and still be careful about crowds and maybe act like you weren't vaccinated until we know more.
No, I think that's great advice. I'm glad you brought that up. I think we still have to keep in mind the public health preventative measures. And I would venture to say, and I know this is being recorded, but even though the CDC in different states are saying, let's, be free of masks, we have to be very cautious, especially in our patients and those that are on the stronger immune therapies, because we need to learn more about what the vaccine response and whether they truly are protected or not, and what is that protection. And maybe we'll find out, oh, there's a robust T-cell response, and that is all you need on certain therapies. More to come with that.
Right.
Another tricky question. So does the potential need for revaccination or boosters in the future affect decisions about higher efficacy DMTs? So I can start with this. I think you have to treat the person that's sitting in front of you, right? MS is a bad disease, especially in some of those patients that have what we call highly active or aggressive MS. And so you really have to have that shared decision-making and think about what are the pros and cons of holding back a treatment that conceivably has greater effect on MS versus what is their chance of getting COVID, et cetera. So I personally have not entered this into my equation, and maybe this will change, as we learn more. But I would say that I'm treating people very similarly to how I was treating people pre-pandemic as it relates to this. And I know we'll probably get into some of the data with the COVID-MS registry and others. I think, yet again, this is reassuring me that we need to treat the person that's in front of us. We need to treat the disease that could get them into major trouble if they have a disabling relapse. So I don't know what your thoughts are.
I actually fully agree with you, Scott, on that. I think we have to really, unless the patient is really, really concerned about a theoretical booster down the road, to me, this is, we treat the patient, we treat their MS, and we worry about that potential theoretical revaccination or booster in the future when that time comes and we get their disease under control now.
Yeah, because we need more data. Are there special considerations for vaccination during pregnancy or breastfeeding in the MS population? And I know you've looked at the data around this, and so why don't you spearhead this one?
Okay, thanks, Scott. This is a great question too. And just recently, in probably the last couple of weeks, a study of vaccination during pregnancy and its safety has come out, and it was totally safe for women who are pregnant to be vaccinated with at least the mRNA vaccines. And so the CDC is recommending it, and they're recommending it for another reason too, which is that it's now pretty clear that women who are pregnant who get COVID-19 itself are at higher risk for being hospitalized or worse if they should get COVID-19. So I think it's particularly important for people who are pregnant. I'm not aware of anything on the breastfeeding front, but I would, but babies get antibodies, some antibodies through the breast milk. And so it could be important for them to get those antibodies. So I wouldn't say not to vaccinate while breastfeeding.
Yeah, no, I agree. Okay, let's get to the live audience Q&A, and I see they're stacking up, and we have, let me just do a time check here, about 15 minutes left. Boy, oh boy, okay. So for patients that are early B-cell repleters and on ocrelizumab, would you have these patients vaccinated at earlier intervals than recommended? Oof. That's, Anne, why don't you take that one?
Okay, so that's an interesting question. So I think the question is, if the person tends to get their B cells back at month 5 or 4.5, would we change the vaccination schedule for them? I mean, that might be an ideal time to vaccinate even with a 2-shot vaccine, where you have 3-4 weeks to do that, but then you want to leave 2 weeks on the other side before the next infusion. So 2 weeks after the second booster, in other words. So I think that could present an opportunity. This is totally off the top of my head. I don't have any data on that, and it may be that won't be true at all.
No, but I think I agree with you. I mean, if we look at the Veloce study and where some of the National MS Society guidance comes from with ocrelizumab, that 12 weeks, after last infusion, we feel at some level, based on those data, that there could be an immune response that's acceptable. That you could even think about that in early repopulators. Although, I think you were one of the ones that said, well, why would you wait that long when you're depleted, probably the greatest? And I took that to heart, because I thought about this before the webinar, and I'm like, that is true. But, for the study, they wanted to use that 12-week time period purposefully to see if there is still a humoral response when you were at probably the innate or B cell count, at least peripherally. So there was a reason for that. So I don't know, more to learn with that. I'm not sure about this question. Patient counseling for cladribine. I guess what this is maybe asking is, if someone is a candidate for cladribine, how are we counseling them as it relates to getting vaccinated? And I know I went through that one slide very quickly, but the data from the Israeli group showing that there didn't seem to be much of an impact of blunting the vaccine response on cladribine, and further, even looking at the timing from last cladribine dose, there didn't seem to be much of a blunting of effect. I mean, I would say for me, based on the scant data, mind you, but the data that's there, I would feel comfortable someone getting vaccinated really anywhere throughout the course of cladribine, if they were already on it, and then still waiting that 2 to 4 weeks prior to starting to get the full vaccine response. I don't know if that's your.
Yes, I agree with you. I'm telling my folks on oral cladribine just to get vaccinated when they can. And if they get vaccinated just before one of their treatment weeks, then to maybe delay that week a couple of weeks.
Another interesting question. So are any of the vaccine trials in immunosuppressed patients measuring T-cell responses? And then second question, are the registries capturing incidences of COVID disease post-COVID vaccine? So, and what do you know about?
So, okay, so I can answer the second question about our registry, which is no, we are not yet, but we certainly plan to try to check the rate afterwards. And by the way, I believe in that Israeli study, they did have 3 people in their 500 and something people who got COVID-19. I think at least one of them was asymptomatic in the weeks before their booster. And they were all mild, but the booster seems to be necessary. So remind me, Scott, what was that first question?
Yeah, the first question was, are there any ongoing trials that is looking at T-cell response, and especially as it relates to immunosuppressed patients? And I do know that there are. Pharmaceutical companies obviously are very interested in this because of their medications that are higher efficacy have that blunting effect. And then what we talked about earlier, just because there's not a robust humoral response, there could be a T-cell response that's protective. And so the answer to that question is yes. Let's see, is SARS-CoV-2 IgG sensitive enough? And how can you explain negative results in healthy individuals and or patients who were not on any DMT? Oh, that's yeah.
Well, they definitely are reported. In fact, there was one in the healthy controls in the study that you presented, Scott. One of the healthy controls didn't have IgG. So it may not be sensitive enough. If you were to check it, which I am not recommending necessarily, but you would have to be careful to make sure you checked the antibodies to spike and not some other portion of the virus to make sure you were actually checking that. But, older people sometimes don't respond to vaccines as well. In fact, we know that with the flu vaccine, a lot of times you have to get the stronger vaccine if you're older. So it could be partly that. It could be, a recent infection has altered the immune system. And one can think of a lot of different reasons, but I personally do not think that the IgGs to spike that are available commercially are necessarily sensitive enough to make decisions on. But the people that I've done it on who kind of insisted that they wanted to have it done and it was negative, it's been, disappointing to them, but on the other hand, they know they have to be careful.
Yeah, no, I agree. I mean, I think, it's like with any test that we have in medicine, right? There's a certain sensitivity threshold, certain specificity threshold, and there's no perfect test, right? So I think when you look at, though, the group data is reassuring for the most part in terms of using these tests to show some response, but we just don't know what to do with it as of yet. Like, what do you do with that information? So, similar to you, I have not been traditionally checking, and I don't think I've actually checked anyone's antibody response as of yet. In the research realm, it's different. Clinically, I don't know what to do with it. So to that, there's actually a really interesting question here. How do we support the individual who does not develop antibodies to the vaccine? And I'll add another sort of twist to this, because I think I know where this is going. So if someone doesn't have a vaccine response based on that antibody level, and they're on a therapy that we know is going to attenuate that vaccine response, and they want to come off the therapy. What do you tell them? Like, how are you supporting them through this? And they need this high efficacy therapy. So what are you doing, Ann?
So I tell them that they need to know, and actually we can move to the next slide because I think it will be helpful here. So I am trying to tell all of my patients and my friends and family members about the monoclonal antibodies cocktails, we'll move back one, that are available now under emergency use authorization. They're cocktails because there are 2 monoclonals in each one, and they're directed against spike protein as well. But you take these by vein if you have laboratory positive COVID-19 and you have symptoms, and you try to do it ASAP after symptoms, certainly within 10 days, if not less, much less. And these are extremely effective, 85% effective at keeping people out of the hospital and off ventilators or worse, even if they are high-risk people. So high risk would include, I think, having no vaccine response if that were the case. So I think we have this in our back pocket, and these are good and very effective and easy to get. So, and it's one infusion that's very short. I've actually given this to a number of patients, and seemingly, you know, again, anecdotally, they get better the next day.
And so what I'm hearing is, for those people that you feel strongly about them staying on their disease modifying therapy, regardless, you pick it A, B, C, whatever the drug is, you're reassuring them that there are things that can be done if they were to get COVID-19. And you know, that list of websites and potential therapeutics, which is growing, by the way. I mean, it expands, which is great. So I know we're running out of time, but I do want to try to get to a couple more questions. Is it reasonable to order a 3rd vaccine shot for those who do not mount a good antibody response? So, you know, we've talked a bit, I think, during this hour, measuring that antibody titer. We don't know what it means, whether it's low or absent, as it relates to protecting people from contracting COVID. So I personally have not recommended any additional shots, like a booster shot. And I don't even think it's available right now, to be honest. I don't know if you know, Ann, but so even if someone has not a really good vaccine response, again, I'm not sure what to do with that information, hence why I'm not actually even testing it right now.
Yeah, I mean, I think I agree with you, and I think we're going to get some guidance on booster shots pretty soon from the CDC, because they are, you know, companies are furiously looking for boosters that will cover some of the variants that are spreading around the world. So that this question may be taken out of our hands pretty soon.
Well, I'm glad you mentioned variants, even though there wasn't a question that came up here and we didn't talk about it. So there's emerging data showing that the current available vaccines do have an impact in preventing contracting the variants, including the India variant. I actually just paper, I think it was published yesterday, showing the impact, the favorable impact in preventing contraction of that variant. So I think that's important to think about. So when you watch CNN and your anxiety levels are going up and hearing all these variants, there still is an impact. So get vaccinated if you're not vaccinated is sort of the key. One more question, and then I think we have to wrap up. I know the Pfizer vaccine hasn't been approved for youngsters 12 to 15. Is that guidance still applicable to kids with MS?
I don't see why not. Do you, Scott?
No, I mean, I think the just hot off the press, go to the National MS Society website. There are above 12 years of age, kids are allowed to get vaccinated right now. And that's sort of, the general healthy population. But our guidance collectively, including pediatric MS specialists, has said, youngsters get vaccinated if they meet the age requirement. Okay. Well, those are really great questions, actually very thought-provoking, and
Yeah.
have not heard yet in clinic. So it's really, really cool. So Anne, why don't you take us home?
Okay, we have one last slide, which has some websites for you, covering different things. The first one is the guidance that the National MS Society has online that Scott has mentioned several times, and please go there. And this is changing all the time. It was, as he mentioned, it was just updated for children. And then there's another project that I'm not as familiar with called Vaccine e-Response that you can go to, and I believe this is a patient a place where patients can put in data. And then for healthcare providers, there's the COVID-MS registry, the third bullet point here, that is now has over 3,000 people in the registry from North America. And these are all people with MS or NMO or very similar to MS type diseases, but the vast majority are MS. And that we've learned a lot from this particular registry. And then just for general information on vaccines, there's a couple of bullet points with sites that you can go to look at. I was just going to mention that on the CDC, the death rate for people who have been fully vaccinated in the US is now running between 1 in 500,000 and 1 in a million when they get COVID-19. So it's really, really effective. And then if you do get it, your disease is less severe. So.
Yeah, no, I think what I've told people is get vaccinated, and because that's going to save lives, save hospitalizations, and you'll have milder disease if you were to get COVID. And then think about your loved ones around or people you don't even know that you cross paths with. And so it's really important. This is a public health crisis that we have to come together. So, okay. Always a pleasure. And we have to do more of these so I can give you more questions and I can learn from you.
Lots of fun, Scott. And
yeah, this is great. And I guess eventually we'll get the plug pulled out from us. But thank you everyone for tuning in. I know it's late at night on the East Coast. And more to come. We'll have more of these webinars as we learn more information.
Bye, everyone. Have a nice evening and a nice holiday weekend.